My name is Heather Hayes. I'm the chair of the Stroke Special Interest Group, and I work out of the University of Utah, and I'm very excited to be here today with Jacob. Jacob, can you introduce yourself?
Yeah, hi. My name is Jacob Striejewske, and I am a third-year SPT, also at the University of Utah.
So we've taken a look at the impairments, and we've kind of narrowed it down to more spasticity, extension, synergy is our primary concern. But so Jacob, if we tell the patient that we need to really work on dissociating her pelvis, what is that going to mean to her, and what else might we want to look at?
It probably doesn't mean anything to her. I think it's important to show her how it will change her gait functionally, especially since I think her main goal was to walk faster to keep up with her kids. So I think if we can sort of test those, get baseline measures of those, and then show her as we disassociate her pelvis, as she can increase her gait speed, then she knows it's working.
Mm-hmm. Good. What else might you want to assess that might be meaningful to her?
I'm still concerned about fall risk, if she's what her confidence is in it, and if she has been falling. I think that'll help guide treatments at the very least, to know how much to progress and how much to load her.
So if we think about the ICF model, we have our impairments, and then are there any functional limitations or participation measures you'd like to measure?
Functional, yeah, I think we could do, like I said, lots with gait. Participation, I think we could also give her some of those outcome measures, like the confidence scales and how well she thinks she's doing around her community.
Great. And what might be some functional measures you'd want to assess?
So I think, again, since her main goal is increasing her gait speed, I think the primary one is probably the FGA, the functional gait assessment. I'd also like to see, we didn't really talk about this in impairments, but I would like to see just generally how her balance is, static and dynamically, just because I don't know how that would change some of the impairments that we found. So I'd want to see, some of the, like the Berg balance scale, and then functionally some of her strength and speed, like the tug or 5 times sit to stands, those kind of tests.
Okay, great. So, and are you familiar with the core outcome measures?
Familiar. Don't make me recite them.
That's okay. That's okay. All right. So the Academy of Neurologic Physical Therapy came out, I believe it was 2018, with a core set of outcome measures for patients with neurologic dysfunction. And this was the effort of this was to not have us take on 50 types of outcome measures that we could do, and maybe it was this for stroke and this for Parkinson's and this for MS. So they identified the 5 measures that were appropriate for individuals with neurologic conditions across all settings. How they divided them were, they wanted to make sure they had minimum measures needed to quantify function and balance, walking speed, walking endurance and distance, and transfer ability. So the 5 measures that they identified were gait speed with a 10-meter walk, and that's a 6 meters within that you measure. Walking endurance is a 6-minute walk. Transfer ability is 5 times sit to stand and giving you a strength assessment. We have balance as the activity balance confidence scale, and that'll give you a sense of how they're walking in the community. The Berg balance scale, and the functional gait assessment. So we get kind of a dynamic and a static balance assessment. Now, what they really want you to think about when you're doing these measures is, does the person have the goals and the capacity to improve in these areas? So you may have somebody who has a goal of doing something, but really you kind of recognize that this is maybe a progressive disease or something that may not be relevant. So I think it's very appropriate that we consider these measures for this individual. So if you go to the AMPT core set of outcome measures for adults, you'll have resources. It's the NeuroPT Practice Resources Clinical Practice Guidelines. And under this, you'll get your assessments. You have, if you have not had a chance to take a look at the free online Synapse course, this is a great way to learn the measures. And they also have environmental setups. They have quick guide for administration. You could just have your pocket card there, quick references, and then eventually we can get into the knowledge translation report card. So here are the measures. So are there any of these today that you might want to clarify how you might do them with this individual?
The one that sticks out to me is the 5 times sit to stand, since we were talking about spasticity limiting your ability to gauge strength, I guess. I don't know how that would change our interpretation of the data.
So it sounds like you're asking, does she have, since this is more of a assessment of strength, you're asking, how would I do that when I didn't do any manual muscle testing?
Correct.
Okay, great question. So we need to differentiate kind of that manual muscle testing when somebody cannot produce a pure contraction of the muscle because of the synergies, meaning you're going to get that extra overflow from the over joints as they are trying to produce force production. These now become functional assessments. So if you think about her trying to give you a quad set, truly isolating the quads to manual muscle test, what you really want is that pure quad assessment. This allows her to use whatever functional pattern she has, whether she chooses to use her extension energy or not, and she only stands on one leg, but it lets you see what is her capacity to perform a 5 times sit to stand. And you may note that she heavily leans to one side, but what we really are interested in is her capacity to perform this and whether she does it one-legged or not, right? We want to know what is her capacity to get out of a chair as quickly as she can for strength. We would hope to integrate that as well in our treatment.
Great.
Okay. And so this is a very specific measure. So you ask them to stand up and sit down 5 times in a row as quickly as you can. When I say go, you want them to fully stand up. Try not to touch the legs on the back of the chair. That would, if they do that, you would want to note that as a deviation. And technically, you would not be able to report it. But just because that's allowing them to use another pattern to be able to stand up instead of just that pure sit to stand capacity. If they can't use their arms, you would also call it a 0. And there are some cutoff data. This is for healthy elders. And then here we are for stroke. So we have some cutoff values for chronic stroke. It should be greater than 12 seconds. Not as doing as well as a healthy individual. Any others that you might want to look at?
Well, like we said, definitely the FGA was necessary for her. I think both the 10-meter walk and the 6-minute walk would also be good for her to perform as well. They would give us a lot of data, especially as she, like you said, especially as she improves over time. And then also, like you said, I think Berg balance scale would be important for her to get a measure of, just to make sure she's at least not increasing her fall risk.
So you ask the individual to walk down 6 meters, which is all now part of our 10-meter walk. So you can use the same environment. And you say, just walk at your normal speed from here. And you're going to time them and get a sense if they were less than 5.5 seconds. And then all of these criteria have to be met to be normal. No assisted device, good speed, no evidence for imbalance, has a normal gait pattern. So what you've seen from this person so far, would you be able to score them a 3?
No.
Nope. So now we get into, do you think she has mild gait deviation, abnormal gait pattern? So let's say that she was an individual that walked 6.4 seconds. Which choice would you choose, a mild impairment or a moderate impairment?
6.4 seconds, likely a mild impairment.
Okay, agreed. So you kind of have to make a choice here though, right? Am I going to choose 7 seconds as my criteria or mild gait deviations? And I feel like she has mild gait deviations. If you look at this, I want you to walk as fast as you can. And when I tell you, I want you to walk as slowly as you can for the 5 feet. So without loss of imbalance or gait deviation, shows a significant difference in walking speeds between normal and fast, deviates outside of the walkway. So in this criteria, let's say you find that she can truly demonstrate a change in her gait speed. She walks at what we saw before, 6.4 seconds, and she can speed up to demonstrating something around 5.2 seconds. What would you then want to measure her?
I think that would probably give her a 3.
This would be something that you need to consider. It is when she demonstrates that change that you might see some mild increase in gait deviations. But it looks like we didn't, so she looked just the same, but you would want to be differentiating a 3 and a 2. I want to make sure that we don't penalize her for her gait deviations over time. Stepping over an obstacle, because this is a common one for stroke. Okay, so what would you anticipate she's going to do when you say begin walking at your normal speed? When you come to the shoebox, step over it, not around it, and keep walking?
For this patient specifically, I would imagine that she would likely try to circumduct around the block instead of over the block.
And then the question is, do you think she can actually truly lift that leg up and over the box?
Based on what we decided her Fugel-Meyer score was, probably not.
However, what she might do, and this would be something that you will see, she can probably stand there without assistance, but she may choose to kind of adjust her steps so that she actually has to take her right foot over, and then she won't circumduct it. So she may want to do that because she knows if you tell her specifically you cannot take that leg around, she's going to try to lead with the right leg instead of having it drag behind. Do a brief task analysis of what has to happen at the hip, knee, and ankle.
So you need the dorsiflexion to be able to clear your toe. Same with knee flexion, and then active hip extension in order to ambulate back.
Yep. And so all of those are impaired, right? We have
Right.
impaired active dorsiflexion, difficulty with hamstrings because of quads, and trying to actively contract glutes would be very difficult. So she's probably going to use more of that retracted hip, and she's just going to slide that leg back, straight-legged. And then use the other leg to go